So Dr. ENATSU, he's working with us for quite some time. He graduated from Kagoshima University and was awarded an MD in 2005. He completed his clinical training in neurology in 2011 in Kameda Medical Center and received a PhD in reproductive medicine from Kobe University School of Medicine in 2015. He has been working for infertile couples, both men and women, at Hanabusa Women's Clinic since 2018. So I want to welcome right now Dr. ENATSU.
Okay, hello. Can you hear me and see me clearly?
Yes, perfectly.
Okay, I will share my screen. Okay, so thank you for your referral and thank you Igenomix to give me such an opportunity. Today I want to give you the presentation and the title is Does ERA Test Create New Error in ART? So let me begin. Before talking about ERA test, let me show you the history of ART. ART has evolved since the birth of IVF in 1978, and some new technologies pushed the stage of ART up to new era. Some representative milestones in 1980s are the use of GnRH analog and transvaginal oocyte retrieval, which makes the ART more efficient and easier. In 1990s, the clinical use of ICSI makes IVF success rate much higher, especially in patients with male infertility. And in 2000s, blastist vitrification technique and PGT brought the field of ART into next stage. So now we are in the PGT era. As you all know, PGT is known to increase clinical pregnancy rate and reduce spontaneous abortion rate, and as a result, increase the live birth rate per embryo transfer. This is the outcome of our clinic of PGT. As with many reports, pregnancy rate after embryo transfer without PGT decreases when women's age is over 35. In contrast, pregnancy rate after PGT did not change regardless of women's age. Moreover, PGT is known to reduce the spontaneous miscarriage. Naturally, clinical pregnancies sometimes result in miscarriage, and the miscarriage rate without PGT increases by age. But the miscarriage rate after PGT did not increase by age. As a result, the differences of live birth rate per embryo transfer between with or without PGT increases by age. Similar results were reported by many researchers. For example, the analysis based on UK data bank reported a similar result as ours. Likewise, the analysis of USA reported a similar result, and the fact that PGT increases live birth rate per embryo transfer is now the common understanding all over the world. However, gradually we got to know that euploid ET doesn't always result in success. In fact, when we see the data of almost all reports, we find that about 50% of euploid embryo transfer resulted in unsuccess. In the PGT era, the importance of implantation failure is increasing. When we think about the cases with pregnancy negative after embryo transfer, before PGT, we can say that, well, it's probably due to the embryo factor. So let's try next one. But after PGT, we think that we cannot say as embryo factor. So how should we explain? In these cases, we come to use the word implantation failure. Aside from embryo factor, implantation failure is considered being composed of many factors, mainly uterine factors. Among these factors, recent topics would be implantation window, immune dysfunction, and chronic endometritis. And among them, implantation window is the most evidence-based factor, and many physicians already use it in daily clinical field. As you know, the concept of implantation window has changed by ERA test. ERA, or endometrial receptivity analysis, was first published in 2011. The research object was to consider the endometrial factor and determine the potential to personalize this in the IVF workup to ultimately synchronize embryo transfer to a receptive maternal endometrium. So in this study, endometrial samples were obtained in proliferative phase, pre-receptive phase, and receptive phase. And the gene expression in each phases were assessed and divided into several clusters. For example, this cluster of genes was represented by 37 genes whose gene expression from the proliferative to the pre-receptive phase is low and showing a sharp increase at the receptive phase. On the other hand, this cluster was formed by 72 genes, which down-regulated in the receptive phase. So therefore, if we check these genes in tissue sample, we can know that the phase of the endometrium. By using this method, ERA can identify the window of implantation lasting 30 to 36 hours, depending on patient, which usually occur between cycle day 19 to cycle day 22, or progesterone plus 4 to progesterone plus 7 in hormonal replacement therapy cycles. Based on the receptive period, the timing before that will be identified as proliferative or pre-receptive phase. Similarly, the timing after receptive, it will be identified as post-receptive. In the clinical situation, when the patient underwent embryo transfer during receptive period, the implantation window is open and is able to accept the embryo. But when the patient underwent embryo transfer during post-receptive state, the embryo will miss the implantation window and the ET will result in failure. Now we know the principle of ERA test, but our concern is that how effective is it and to whom we should recommend. Until recently, many researchers have reported the effectiveness of ERA test. Among them, this is the largest multi-center randomized controlled trial reported by Dr. Simon. In this study, 458 patients aged 37 or younger in 16 reproductive clinics were randomly divided into 3 groups: Rosenthal ET cycle with or without ERA, and fresh ET cycle. The result revealed that the implantation rate of first ET attempt was significantly higher in groups with ERA test. Similarly, cumulative live birth rate after 12 months was much higher in groups with ERA test. This result indicates that ERA test significantly improves ET outcome. This is the outcome of PET or personalized ET after ERA test in our clinic, which included 265 cycles aged 39 in average. The clinical pregnancy rate of PET, including all ages, was 53.2%. It is considered to be better than normal frozen solid ET outcome. And when it comes to the result of PET using euploid blastist, the clinical pregnancy rate increased to 64.4%. This is significantly higher than the result of euploid blastist transfer without ERA test. Therefore, in my opinion, PGT plus ERA could be the most reliable method in the present. Similar results were reported by many researchers, and most of them concluded as ERA test improves clinical pregnancy rate. However, when it comes to the result of PET with use of PGT-A, as far as I know, no research could prove the efficacy of ERA test. It was against my expectations. And when we focus on the very recent reports, the negative reports are dominant. So I have to say that effectiveness of ERA is still controversial. But why the outcomes vary by reports? Until now, we have discussed about the implantation window period, which is the duration that endometrium maintain its receptivity. But in this discussion, we have forgot about the buried period of embryo, meaning that the duration that embryo has its implantation ability. For example, when the embryo were transferred in receptive status, it resulted in success. And when the embryo were transferred in post-receptive status, it will result in failure. That is understandable. However, if the embryo was transferred in pre-receptive status, will it result in unsuccess? No, I cannot say that this must result in unsuccess. Let us think about in two situations. First, if the buried period of embryo is short, the embryo will be in decay before the implantation window opens. Then this attempt will result in failure. But if the buried period of embryo is long enough, embryo can be wait until the implantation window opens. And in this case, ET will result in success. So the next concern is that how long is the buried period? In other words, how long can you wait for implantation period? Now, let us refer to the cases of other mammals. In cases of roe deer, in the mid-1800s, hunters observed that there was discrepancy between mating time and birth, meaning that pregnancy seemed to continue far longer than expected. And after 100 years after, biologists found that the blastist development was retarded for 4 to 5 months. This phenomenon is called embryonic dipoles. Why does it happen? In case of brown bear, the mating period is from May to June, and fertilization occurs thereafter. The bears accumulate nutrition during summer until fall. It is known that brown bears with less than 20% body fat didn't get pregnant even when mating had occurred. And in November, after bears accumulated enough fat, they hibernate in caves. Then the embryo finally be embedded in the uterus. And after 2 months of pregnancy, they give birth in the caves, and this will be the best timing for breastfeeding in the safe environment. So what I want to say is that the embryo can wait for the best timing for implantation, about 180 days. And this phenomenon of embryonic diapause is observed in many other mammals. So, like other mammals, embryonic diapause may happen in humans. There has been some reports considered human embryonic diapause. For example, Dr. Nichols reported in Nature News that human embryos may be able to temporarily suspend embryo development very early on this pregnancy. But it is very hard to prove it because we cannot directly observe inside uterus of pregnant women. So we have tried to prove it indirectly by retrospective study. This graph represents changes of serum HCG level after pregnancy in over 1,000 cycles, 8,000 cycles of ET at our clinic, resulted in single birth. As you know, the serum HCG level increases exponentially after pregnancy. So when we convert the y-axis into logarithmic manner, HCG increases linearly around here and reaches plateau at day 17 to 19. This indicates that the changes follow in a logarithmic pattern. Then the next question is, when is the point zero of HCG? So when we draw the logarithmic curve line, we can speculate the date of HCG zero, and it was about 3.2 days after embryo transfer. This result represents that the blastocyst introduces HCG into maternal blood after invasion, which usually occur after 3 to 4 days after embryo transfer. In the next, we compared the HCG changes between HCG high group and low group at 10 days after embryo transfer. HCG changes in parallel regardless of starting HCG levels. This is understandable when we consider the clinical experience that the HCG increases about 10 times in 5 to 7 days in successful cases. In the next, we compare the date of point zero of HCG in high HCG group and low HCG group using logarithmic curve line. And it revealed that the date of zero HCG differs almost 5 days. It reminds us that this fact may represent the minor diapause embryo in humans. At last, we compared the blastocyst characteristics between high HCG group and low HCG group at 10 days after embryo transfer. So in high HCG group, the ratio of high-grade blastocyst is 19.9%. On the other hand, in low HCG group, it was only 47.4%. Similarly, the average grade of blastocyst in high HCG group was 4.72, and in low HCG group, it was 3.15. So blastocysts in high HCG group are more matured than in low HCG group. This fact indicates that implantation timing differs from embryo characteristics. Therefore, in my opinion, if the time to implantation differs from embryo, we need to check not only window of implantation in uterus, but also time to implantation period of embryo to synchronize the implantation timing. So my conclusions are the importance of ERA test is increasing in the clinical field. PGT plus ERA may be the highest expected method in current art. Further research for embryo implantation period may strengthen the efficacy of ERA in future. Thank you for your attention.
Thank you, Dr. ENATSU, for your time and your presentation.
Thank you.
We have selected 3 questions from the audience for you.
Okay.
The first one, for patients who had frozen embryo transfer following PGT-A and ERA and were not successful, what else would you do before the next frozen embryo transfer?
Well, that is a very difficult question, and we sometimes face that problem, and there is no certain answer. But in my opinion, is that in this very difficult situation, we recommend other tests for implantation failure, such as immune system, or such as hysteroscope to check up the chronic endometritis. And also sometimes we may use PRP before the embryo transfer.
Thank you. So yeah, this was the first one. Thank you for your answer. Moving on to the second question. Is there any HCG level difference under day 5 blastocyst embryo transfer or day 6 blastocyst embryo transfer?
Well, I think it is a very interesting interesting question. And well, in our study, we found that the blastocysts in high HCG group are more matured than in low HCG group. And but unfortunately, I didn't check out the day 5 or day 6. So I will check it out later on. But in my opinion, so far, well, the unmatured blastocysts, like grade 1 or grade 2 blastocysts, will be tend to hatching. They tend to implant in later timing. So maybe in these cases, we can delay the date of embryo transfer. But I am not for sure at this moment.
Understood. Thank you for sharing your experience.